Good afternoon, West African time.
Good afternoon, ma'am.
Good afternoon, everyone. Welcome to today's learning section, NSIC ECHO section. We're happy to have you all here. Let's just give a few minutes for other people to join us. Thank you.
Welcome.
To this afternoon. You're welcome to this afternoon's ECHO session. Today, we have a very interesting topic. We'll be looking at cholera, situation report on cholera, case management and identification, and IPC measures in cholera management. We have with us three renowned scholars, an experienced clinician, epidemiologists, and pathologists. So from the agenda, you can see that we have Dr. Abiodun Aguniyi, who will be giving us situation report on cholera from the Nigerian Center of Disease Control. Then Dr. Akase Iohen, who will take us through case management and identification. And then Dr. Sanda Abdallah, who will take us through IPC measures. So it is with great pleasure I would like to introduce Dr. Abiodun Oguniyi, who is a distinguished epidemiologist and medical microbiologist. He has been at the forefront of Nigeria's reputation for excellence and a passion for saving lives. He has led outbreak responses both within and outside the country and was among the first 10 responders to Ebola outbreak in Nigeria. He was also at the forefront of the COVID outbreak response and has leveraged on his expertise in infection prevention and control, epidemiology and microbiology, and risk communication for significant contributions towards the containment and defeat of these threats. Dr. Oguniyi's unwavering dedication to global health security has earned him recognition as a champion of public health, and his work continues to inspire a new generation of leaders in this field. At the Nigerian Center for Disease Control, he was the immediate past national IPC program and head for subnational advocacy on health security and health promotion. He's also the serving national deputy incident manager for the Cholera Emergency Operations Center. So it is with great pleasure I call up Dr. Abiodun Oguniyi. You have the floor, sir. Thank you. Over.
All right. Thank you very much. Good afternoon, everyone. I hope I'm audible.
Good afternoon, sir.
Thank you very much. So if my slide could be projected. Okay, thank you very much, everyone. So it's a pleasure to be on this conversation today. And I want to appreciate also the organizers for the opportunity to share our thoughts with respect to the update on the national cholera outbreak response here with us. I remember with nostalgia my experience with NCIS when I think it was the inaugural conference that was held at Barcelona Hotel some years ago. I think I was there then. So today we, on behalf of NCDC, bring us updates on this cholera situation, and I commend the effort of the organizers for being part of this intervention. Next slide. Thank you again, Dr. Jen. It's good to hear your voice. Thank you for all you do. Well appreciated, Prof. So I'll walk us through this presentation. Apologies, we may have some noisy interference at the background. We are currently at the Legislative Health Summit here in Abuja, where we're addressing issues relating to health and the legislative related concerns. Please bear with us. So I'll walk us quickly through this update on cholera situation, then appraise the related risk and challenges we've been having that are very recurrent, and then provide some current response effort. And at the end, we'll be able to solicit the kind of sustainable approach which cut across the sectors in the country towards controlling this outbreak. Next slide. So a bit of the background. As we know, this disease has been with us. At least this is the 7th pandemic that the world is reporting. And the current pandemic that is still spilling over to the moment was in 1971, which, of course, we continue to have the effect in this part of the world. In Nigeria from 1981 to date, we've been having a series of outbreaks with us. And the major driver of this disease, as we know, has been issues around open defecation, poor access to potable water, which is driven by poor sanitation and hygiene practices. Of course, the current cholera outbreaks, as we know, will compromise the attainment of some of the SDGs, which has been a major concern for us in the health sector, because if we look closely at the Sustainable Development Goals, for instance, SDG 3 speaks about good health and well-being, and you know the target 3.3 of it talks about how to combat waterborne diseases like cholera, while SDG 6, for instance, speaks to clean water and sanitation, where the target 6.1 speaks to universal access to safe drinking water, and target 6.2 talks about the need to end open defecation and ensure access to adequate sanitation. Of course, SDG 11 also talks about sustainable cities and communities, whereas the target 11.5 of it talks about the need to reduce the number of deaths and affected persons from water-related disasters like cholera outbreak. The 4th SDG that is also speaking to cholera intervention is on SDG 17, for instance, that talks about the partnership for the goals that helps us to look at areas to enhance global partnership to support cholera response efforts in particular. Next slide. All right, so with this understanding, I walk us through what has been the trend of cholera cases in Nigeria. I take us quickly with the 5 years, 6 years data analyzed from 2018. As you can see from this slide, the yellow line speaks to the 2021 outbreak, which still happens to be the highest. But before then, we had the 2018 outbreak, which was, that's the line, the blue line, and the light blue line we're seeing there. Now, it gives not an impression as if there's a 3-year curve or spike. After 2018, we see the next big curve in 2021. And now we're in 2024, which is 3 years after, and we're beginning to see a trend that is higher than what we had in 2023 or 2022 in that regard. Next slide. Now, a bit more about the current highlights of the epidemiologic summary as at week 28, which ends last week Sunday. We cumulatively have reported in Nigeria a total of 103 deaths from 3,623 suspected cases. And that is giving us a case fatality ratio of about 2.8%. This is far higher than what the global target from GTFCC, Global Task Force for Cholera Control, said, which should be less than 1%. So we're already seeing a case fatality rates higher than the target. And we have currently all the 34 states in Nigeria are reporting at least one confirmed case of cholera across 187 local government areas, that is including FCT. And so it's only Enugu and Plateau State that we're yet to have a reported case from as we speak. Of course, we also know that we are not at the peak of rainy season because we know that from previous trend analysis, the peak of rainy season also coincide with the peak of cholera outbreak. So we still have weeks ahead for us to really know the true burden of this disease. So breaking it down further, 92% of suspected cases are reported from 10 states. So 10 states contribute a total of 92% of these cases, with Lagos having 57%, Bayelsa 13%, and the other statistics as highlighted. Breaking it down to local government level, out of our 774 local governments, we'll be able to see that only 15 of them account for about 60% of these cases, and they're largely more of their LGAs in Lagos and Bayelsa also. When it comes to persons affected, we still sadly have under 5 age population mostly affected, and there's just little difference in proportion between the male and female, the gender disaggregation. We have males slightly more affected. At our own level, we continue to have a National Cholera Multi-Partner Multi-Sectoral Emergency Operation Center coordinating this response. And I'll tell us more about what we're doing. Next slide, please. So, having looked at this, I want to also walk it down a bit to some specifics. Can we have next slide? I hope it's not my side. The slide is not moving. Okay. So this has been mentioned, so we can just move on to the next slide. All right, so a bit of the epidemic curve will help us understand what has been the trend in this particular year so that we kind of disaggregate these cases by weeks of occurrence. And you can see we have cases right from week 1, sufficient for us to know that cholera is a disease that actually happens around the year. We have it at an endemic level in some locations. And when we start having the surge, then we declare an outbreak. So we see that the current outbreak started around week 23. And since then, even though we've had a bit of decline, like I said earlier on, it's not yet to cool. We know that the rains are still coming, like in the northern part of the country. If we look at the data I showed earlier on about these affected states, you'll see that 7 out of the 10 high-burden states are southern states. This is a shift from what we used to have that we describe as cholera of the north, so to say, because we always have the northern state leading the number of cases before. Of course, there has been some interventions in this regard, but I believe it's also likely associated with rainfall that has not really been at the peak in the north yet. So we may not be able to totally conclude on the actual body. Next slide. So speaking to issues around death, this is also breaking it down further to help us see the death trend. You can see also that from week 24, when we started having more interventions on this response, there has been a steady decline in the number of reported deaths across the state. Next slide. So leaving a bit now to other epidemiologic descriptions, characterization of cases. Can we have the next slide, please? This is a bit of challenge when one is not concluding the slide. There's a lag phase between when the slide is moved and when you see it. Can I confirm the slide is moved? Okay. So then a bit of gender disaggregation of the cases we have, which I've mentioned earlier on. So this is already captured. You can see the age group, less than 5, followed by age group 25 to 34, and then 6 to 14 in that regard, or 5 to 14 in that regard. Next slide. Now, this speaks more to the distribution of cases across the states. This has been updated now because we only have 2 states that are yet to report. So all of this graphical representation were actually earlier summarized just for us to appreciate this pictorially. Next slide. So now moving to what are the concerns, what are the challenges, what are the risk factors we've identified. I think we can just skip this slide. Let's move on to other things because of our time. I've said all of this. Let's move on because of our time. We can have the slide later on to check the details. All right, so I'd like to speak about the current challenges with respect to this disease. As we said, cholera is a disease that has been with us over time. And we know that open defecation in affected communities has been the major driver. Cholera, the organism causing cholera, as we know, Vibrio cholerae is one interesting organism that has the ability to survive in the environment for weeks, months, and years. It can survive in high salt environments. It can survive in high temperature, as much as 40 degrees above. And it's such an organism that can easily go into hibernation and reactivate itself when it gets contact into the small intestine and start its replication again. So it's important to see that in addressing this challenge, issue of open defecation is something that we need to take serious. And that's one of the reasons why the Nigerian government has set up the target to end open defecation in Nigeria by year 2025, which is next year. But as we speak, only about 16% of LGAs in Nigeria are open defecation free. So inadequate toilet facilities, and even the existing ones, you enter facilities in Nigeria, you find out that even the toilet facilities cannot be accessed because of poor maintenance. Next to that is the issue of potable drinking water, poor waste management practices, poor food, environmental and personal hygiene practices. These are traditional issues that we know, and they still continue to drive this challenge. Next slide. And then in addition to this, I think we're having some seconds of lag in moving this slide. These are just graphical representation of things that we see daily basis that are really driving these issues of poor waste management practices, as you can see everywhere. But aside that, we look at the issue of weak disease surveillance system. We've had a lot of challenge with reporting from states, especially when cholera is seen as a disease that is associated with poverty, inability of government and to provide potable water for their people and all that. So there's tendency not to report cholera. And then this disease keeps spreading. There's inadequate workforce. We all know what the challenge has been with workforce in the country in recent times. Data quality. And these issues are even worse in our private facilities, where the patients tend to make as their first point of call in that regard. Especially for a state like Lagos, where we have a number of cases, overcrowding, inadequate shelter has also been reported in a number of places where there are slums in that regard. There's suboptimal lab capacity for most of our states. We've not been able to optimize the laboratories to be able to give prompt diagnosis for cholera in that regard. Next slide. We need to move a bit faster because of our time. Then in addition, we've also had facilities that don't even have adequate spacing for managing cholera cases. They don't have dedicated spaces or wards for this disease. And this poses some challenge for a number of them. Workforce capacity, especially at the LGA level, whether for human health or environmental health, has also been a major concern. But in addition to this is the issue of regulation. we're expected to have regulations, public health laws. There's also what we call public nuisance law that forbids people from doing certain practices. You are not expected to build a house without a toilet facility, or you have a shopping mall, you don't have toilet facilities, but there are motor parks that don't have toilet facilities. So you expect that people, when present in that environment, we have to look at other unacceptable options for doing that physiological process. So then we also have to concern with those who are sinking boreholes that are close to water source, that are close to, they're sunk in wrong locations and they're close to toilet facility or septic tank in that regard, which makes it so easy. When there's heavy rainfall, flood comes in and washes, there's contamination of water sources from the sewage and all that. Then we have the challenge with funding, as we know, in that regard, which is also addressing some of these issues, the social determinants of health, poor education, and all that. Next slide. Now, moving on to what we also observe, there's been weak collaboration and coordination among line ministries. Thanks to the presidential initiative of now setting up an interministerial committee that is able to cut across information, education, women affairs, intergovernmental affairs, in addition to the traditional health, agri, and environmental ministries, so as to be able to work together and see how the synergy can provide the necessary coordination, cooperation, and collaboration to address this challenge. But this has not really taken off as much as we expect. Next slide. Right, and then of course we talk about open defecation. Then we still have issue of insecurity, complex and humanitarian and emergencies that have led us to having IDP camps, refugee camps in that regard. Densely populated area without access to water. And you've seen this yellow keg, these water sellers who also go to source for water from where you don't know. A recent study in Lagos showed that when they read open this kind of keg and they sampled the inner part of the keg, very crazy organisms that were isolated from them. So scary, and this is what some depend on as their source of water for doing what they need to do. Next slide. So I'm rounding up gradually. We're looking at other areas that this has also been of concern, the drivers of the risk that have been driving this disease. Of course, poor regulation of vendor and commercial water supply on hygiene. We've had concern around those who initially put a particular drink as what is causing this problem because of poor regulation of food and drinks that are being supplied for people in this regard, which could really compromise their health. Low knowledge and practice of basic hygiene, not that there's low knowledge per se, but people feel like as soon as one disease is over, they don't need to obtain or comply with those initial recommendations. The lessons from Ebola from hand washing, the lessons from COVID from hand washing, why are we throwing it away? So that sustainability part is really a challenge for us in this regard. Next slide. Okay, so a lot has been said about that, but it's also interesting to put these statistics on the table that for the WASH norm findings from school health facilities, market and open or motor parks shows the following statistics. Which are the drivers of this disease also? That it was found that only 11% of schools have basic water sanitation and hygiene practice, 6% health facilities have basic water sanitation and hygiene services, and only 4% of markets and motor parks have these services for people to access. A staggering 48 million people in Nigeria still practice open defecation. That's more than 25%, most likely about 20-25% of our population. Response strategy. I don't know if this person is speaking to us. Now speaking about the national response strategy as I conclude this presentation. We have this approach to lead and mobilize political leadership, partners, and resources to enhance multi-sectoral coordination. We have a target to reduce rapidly the case fatality ratio. We are engaging and empowering communities as much as possible to prevent this disease. And we're interrupting and preventing cholera transmission in areas with active transmission through the interventions that we have in place, which we'll see shortly. And it's also to prevent through mitigation the risk of transmission while enhancing readiness of the population. Next slide. And last 2-3 slides now. This is just the picture showing a graphical representation of the Emergency Operations Center, the Incident Management Command structure activated at the NCDC that is currently monitoring and intervening in this response. So we have the units for epidemiology, surveillance, case management, and infection prevention and control, points of entry, communication and social mobilization labs, logistic research, and even coordination. We also have vaccine pillar, risk communication and community engagement structures are all in place, and we are fully activated at all of this using this multi-sectoral approach. Next slide. So one more slide and it will be done. Next slide. We have discussed all of this. So far, these are the things we have done, provided treatment support to state, advisories to state, and during this outbreak, we have more response commodities supplied to the states and capacity building trainings. And currently we have deployed, next slide, we have deployed national rapid response teams to support the state, next slide, to support the states in their response in this regard. And we believe that with all this intervention and collective effort of critical stakeholders like also this organization, the Nigerian Infection Control Society, we believe that we are better positioned to end this outbreak. But beyond doing a reactive measure, next slide, we are hoping that next season will be more proactive. We have cholera jingles here, IPC guideline and SOP materials are disseminated to states. And we have also enjoyed the strong political will of Mr. President this time around to have this committee that is also working to address this problem. Next slide. And that should be going to conclusion. Yeah, these are the ministry supporting. Next slide. That we hope to also work with and collaborate agencies and partners. Next slide. A number of challenges, we can see this later on, but they are all related to issues we have mentioned earlier on. Next slide. All right, so with the recommendation also, we have things that relate to surveillance, epidemiology, risk communication, infection prevention and control, interventions that need to be enhanced in all our facilities. Next slide. About healthcare worker infection, I forgot to mention, we've reported a few in some states, which we are following up to verify. But unlike other diseases, we've not really had much of healthcare worker infection due to cholera in this particular outbreak. Next slide. I think that should speak to some of the efforts of IPC in ensuring that people are better prepared in that regard. But largely, the wash component of this response, that's water, sanitation, and hygiene, is something that also relates to the core component 8 of infection prevention and control intervention, which relates to our work, and we need to really work more with all the relevant stakeholders in this regard. Next slide. And I think with that, we'll be bringing this conversation to a hope, where we hope to conclude with that last statement that resources are required even after the outbreak, if you can go back. Resources are required after the outbreak to even ensure that we sustain whatever interventions we are putting in place now, so that we are not caught unawares again, waiting for the next outbreak to happen before we run up and down. With this, I'd like to say a very big thank you to the leadership, and we'll be happy to have questions. And I thank you so much for your attention. Over.
Thank you, Dr. Biodun Oguni, for that very, very elaborate and then well lucid presentation. We thank you for your time. We appreciate the fact that you took time for another meeting to make this presentation. We will refer to you. Please, we'll call you back later for questions that will be addressed to you, as we have 2 other speakers to go. Thank you so much. And our regards to all of you at the NCDC. We appreciate what you are doing. Thank you so much. So can we give him our reactions? Let's see the applauses for his presentation. Thank you so much, Dr. Abiodun.
Thank you, Dr. John. Thank you, everyone. I appreciate it.
So at this point, I would like to call up Dr. Yohen Akase. Dr. Yohen Akase is an infectious disease physician, and he's the head of the Infectious Disease Unit, College of Medicine, University of Lagos. For 6 years, he has been a member of various technical working groups including the Public Health Emergency Operation Center in Lagos State. I'm sure most of us can relate to the fact that that's where we have most of these outbreaks occurring, where the majority of outbreaks have occurred. In addition, he currently chairs the Nigerian Infectious Disease Society Epidemic Response Committee and is a member of the Committee for the Development of the National Guidelines for the Clinical Management of COVID-19, as well as the development of COVID-19 training modules. He also chaired the Oyo State Committee for Isolation Facility Accreditation and currently serves on the board of the Pan-African Mycology Working Group of the International Society for Human and Animal Mycology. Dr. Iohen has worked with many other researchers and clinicians to publish over 40 manuscripts in respected international and national journals, and looks forward to leveraging his experience and extensive networks among colleagues to help the country and global partners achieve their collective goals. Please make welcome Dr. Iohen, who will take us through case management and identification. You're welcome, sir.
Good afternoon, Ma. Good afternoon, everyone. I believe you can hear me well.
Yes, sir, we can.
Thank you. I'm extremely honored to be here today. Thank you very much, Dr. Oguni, for that extremely lucid presentation earlier on. So, this in the next few minutes, I will be walking us through this discussion with the emphasis around a few points on the case identification of cholera cases, and then to briefly look at the clinical presentation and some of the salient points, and to outline the principles of management for patients who are presenting with the cholera. So as we've heard, cholera, by way of introduction, is an acute, highly transmissible infection that is caused by toxin-producing bacteria, Vibrio cholerae. And in its severest form, we appreciate that there are some patients who may not have severe disease, but in the severest form, it presents with a sudden onset of highly voluminous acute watery diarrhea that can rapidly progress to complications if they are left untreated. Having said that, we need to make a few points around what constitutes a case for cholera. And central to this case definition is the concept of acute watery diarrhea, which has a standard definition of patients that are presenting with illness characterized by 3 or more loose or watery non-bloody stools within a 24-hour period. This is very, very important for surveillance and epidemiologic purposes, but as well for diagnostic purposes. Once the individual presents with this, it should ring an alarm bell, to that. Now, when do you suspect that somebody is presenting with acute watery diarrhea, maybe having cholera? And this, I've sort of put together a number of thoughts concerning different bodies. The WHO states that in areas where an outbreak has not yet been declared, any patient who is 2 years and older presenting with acute watery diarrhea and severe dehydration, or anybody who is dying from complications of acute watery diarrhea should be suspected as having cholera. Of course, in cases where cholera outbreak has been declared, any person presenting with acute watery diarrhea or dying from that, without recourse to his degree of hydration, should be suspected as having cholera. And suspected case can be confirmed when Vibrio cholerae, either the serogroup 01 or 0139, are confirmed either by culture or by PCR in most countries. In fact, most countries will not have that. But where resources permit, especially in non-endemic countries, there may be instances where they will say, okay, they need to prove that that strain is producing toxin. But we know that most endemic countries do not have this luxury. And so therefore, a case, once we are a culture by PCR or by culture, that organism, then you can confirm that a suspected case truly has, a cholera. In terms of the IDSR, which is standard reporting guidelines at the grassroots, they use 5 years or more, but most of the other criteria that we've used, are essentially, the same. Then CDC also uses 2 years and above, and introduces the concept of community case definitions, where people in the community can also suspect and say any child 2 years and above, which is having lots of watery diarrhea. You can see now it's a community definition, so it's not very, strict, lots of watery diarrhea. But then the suspicion, again, they use 2 years and above, and the rest stands the way we discussed before. So how do these patients present? We know what was known so far is that from exposure to presentation, the incubation period may take a few hours in some cases to 5 days, which is most of where most people present, within. And like I said, depending on which strain is affected, Dr. Winnie took us through some of the strains that are responsible. 60 to 75% of cases may remain clinically unapparent. In other words, they may not present with a florid, acute watery diarrhea, as we know, but they are infected, and these people are able to transmit infections within the community and through close contacts and within home settings. However, about 5 to 10% of people who have cholera may progress to develop severe disease, which is about 25 to 30% of those who have symptoms, but on total, about 5 to 10% of patients who develop cholera may go on to have severe disease. And the initial manifestation of these is diarrhea, of course, in severe disease, which, of course, in its classical form is called the rice water stool, which is essentially a starchy looking diarrhea, which essentially is made of electrolytes and mucus with no fecal material. This diagram that is appearing on the right was gotten from one of the patients that presented in our facility within 3 hours of presentation. This stool, you can see some specks of fecal material still there, but over the next 2 hours, all of this had disappeared, and the stool became, the typical rice water stools, as we know. And it is known that sometimes these patients can lose up to 500 to 1,000 mils, that's 1 liter per hour in severe disease, which is called cholera gravis, which is the severest form. And it is said that this is one of the causes of people who wake up in the morning, have breakfast with their family, and by evening, they have dinner with their ancestors. In other words, it kills in hours. Vomiting may be present, and it was typically colorless, containing no bile and no blood. Abdominal discomfort may be present, but it's not classically crampy, like what you have with most other acute watery diarrheas that are mediated by other toxin-mediated organisms. As we know, it's not typically crampy. Usually, it's an abdominal discomfort that may be because of the profuse diarrhea or because of electrolyte imbalances, as we'll see subsequently, but they have some abdominal discomfort, which is that. Most typically and peculiarly is the fact that fever is not such a prominent manifestation of this disease. Usually, by the time you're having high-grade fever of 38 degrees and more, you should start looking for other causes of that fever, except there is a superimposed bacterial infection. And this is because Vibrio cholerae diarrhea is not typically an invasive diarrhea. It is toxin-mediated, and most of these, as we'll see, is due to a secretory mechanisms by the toxins, that are produced. So in most people, this is going to be the presentation: vomiting and diarrhea with varying levels of dehydration. And eventually, when the diarrhea and vomiting continues, patients will eventually go into volume depletion, loss of electrolytes, and as well as severe complications, which is what puts the patient's lives, at risk. Some of the electrolyte imbalances they may have, like hypokalemia, where there's loss of sodium, low sodium in the blood, may give a complicated picture because sodium is important for intestinal peristalsis. In cases where they have severe hypokalemia, the intestines will stop moving, and all the secreted diarrhea will be pulled inside the intestine within the stomach, and the person may not come with, diarrhea, profuse diarrhea, but will losing lots of fluid within the intestines, and this form of diarrhea is known as cholera sicca, in opposition to cholera gravis, which is, profuse, secreted. Eventually, of course, they develop metabolic acidosis because they're losing a lot of bicarbonate in the stool, and they go into shock. And the kidneys eventually, will suffer. You can see a kidney here is already suffering. And this happens within hours for patients who are developing 500, who are losing 500 mils to 1,000 mils of fluid per hour. It takes less than 2-3 hours, and already kidneys go into shock. And by evening, most of them will go into, anuria completely. Few of them may suffer strokes because of the low blood supply to the brain, especially participants or patients who have predisposing factors to that. So, what are the principles of management? Like I said, we're just approaching principles, so that we don't bore us with too many details. There are essentially 4 major principles that if one, pays close attention to, patients with cholera will do well. The first of which is prompt detection or early detection and prompt triaging. We're going to get into all of this. And secondly, and which is the cornerstone of active clinical care, is replacement of fluids and electrolytes. Thirdly, we'll address complementary therapies, like therapies that complement replacement of fluid and electrolytes. Like I said, it's a cornerstone, but you also have complementary therapies. But lastly, but not the least, is close monitoring for complications, because that will happen very quickly. And if you're not paying close attention to that, even though you are doing some of the basic things, you could still lose the patient if you're not monitoring them closely. So how do you detect cholera early? We've addressed that in the case definitions. Once you have any case of acute watery diarrhea in a patient who is 2 years and above, then especially in an endemic area like ours, especially more so now that there's an epidemic that has been declared, you don't have to wait, to be asking questions. You have to suspect that this could be, a case of cholera. And so you start triaging the patient. Triaging means you start profiling the patient to know how much the level of care that the patient needs to get. And, this includes clinical features in terms of what started first, to paint a picture of what exactly the patient is going through. Are they having, complications already? Are they having features of metabolic acidosis? And all of those things, clinicians here understand, that. But secondly, you want to find out how much fluid they are losing, they have lost so far. That can be captured in terms of how many times they've gone to the toilet, and each passage of stool average approximately. They'll tell you, every time I go to the toilet, I pass like 1 bottle of water, which is about 500 mils or something. You know that is a big problem. And I've had that 10 times already. You know that you have a big problem, on your hands. You need to move very, very aggressively. If not, you're going to have problems. So that. And then, of course, most importantly, you also want to assess the level of dehydration that the patient has. Now you can see the pictures on the right tells you one way to assess dehydration. Already this person is moderate, at least has some dehydration. And then you see this person has a dry lips and very dry mouth, and it shows you clearly this person has some dehydration and becoming quite toxic. It's a danger sign, in a patient that has that. So usually you want to make a decision as to which of the 3 grades of dehydration the patient has, in whom you have confirmed the case of cholera. You want to decide whether the person has severe dehydration, or do they have some dehydration, or do they have no dehydration at all? And this has implications for management. So if patients who have severe dehydration, most importantly, you see them lethargic and have, impaired level of consciousness. They are lethargic, they're confused, are somnolent. It's a bad sign, okay? And they have sunken sides. And a danger sign is when somebody is lethargic, passing their eyes to, and you say, take water, and the person cannot take water, or is, he's drinking poorly. You know that is a very, very bad sign, okay? So it shows you that this person is severely dehydrated. However, when you have somebody who is restless, especially in children, they're irritable, but they're drinking water eagerly, it shows that, okay, there's some dehydration, but it's not yet, severely dehydrated. Of course, if you're able to take blood pressure, you can see that a severely dehydrated person may already be in shock. The pulse may be thready or weak, and all of that. And it just shows you that this is a bad sign, and then, of course, if there's no dehydration, the person does not have any of those other signs. They have just started passing loose stools. and you need to you need to make a decision around what you need to do. So knowing that the cornerstone, I told you, first cornerstone is early detection and triaging. That's what we've done. We'll triage them. What's the level of dehydration? How much food they have lost? You've done that. Secondly, you want to replace fluids and electrolyte. Very, very important. This will save the life of the patient. So you have made a decision, this is severe dehydration, or it is some dehydration, or it is no dehydration. Then you need to know what to do. If they are severely dehydrated, it's IV fluids. You don't do orals because they cannot even drink enough anyway. It is estimated that patients by this time have a fluid deficit of over 8 to 10 liters. They cannot take that orally in the amount of time that is needed. So what you want to do is to give IV fluids. Ringer's lactate is the preferred fluid of choice because, and I'm going to show us a diagram that shows this. It has composition is very good. And you want to give, because it is estimated that they have lost up to 10% of their body weight. So you want to replace that by giving 100 mils per kilogram within 6 hours if they're children, or within 3 hours if they're adults. And you split this 30 mils per kg as a bolus within 30 minutes for an adult, or 1 hour if it is a child. Then, of course, you give the rest, the remaining 70 mils per kg over the remaining 5 hours. So once they improve, of course, you want to start giving them ORS the moment they can start taking already. Okay. Now, but if they have some dehydration, then you can give them oral rehydration ORS because it is estimated that they've lost between 5 to 9%, which is about 7.5% per convention. And you want to replace 75 mils per kg over 4 hours. Very important. And once they improve, of course, you now go to maintenance, which is what you give for people who are having no dehydration, but they're having passage of loose stools. You have to maintain. So how do you maintain? You give whatever they are losing. So I went to the toilet now, you give them ORS to replace what they have lost. And you do that until they have recovered. This is very, very important to making sure that patients survive, the episode of cholera. So you can see why Ringer's lactate is preferred. You can see the composition is balanced, is the most closest to physiology of the normal human. You can see it has sodium, it has potassium, it has chloride and bicarbonate. Very, very important because that's two that a person is rich in bicarbonate. So you want to do that. Normal saline does not have any bicarbonate at all, and it does not have any potassium at all. So Ringer's lactate is best. You want to do that. For ORS, the WHO recommended ORS now has low osmolality because, if you are giving high osmolar fluids when they're having diarrhea, it will worsen the diarrhea. And that is why when people are having, acute watery diarrhea, you don't give them sugary drinks or take carbonated drinks because that will worsen the diarrhea. High sugar worsens the diarrhea. In ORS, the high sugar is balanced by salt. So they maintain the balance of osmolality, and then of course coupled with the absorption of sodium through the glucose sodium co-transporter, it helps to do that. Other fluids can be used like rest-based ORS, and so on and so forth. But most importantly, like I said, after fluids, you want to monitor. Very important. You don't just give fluids and walk away. You will come back and the patient would have died because the patient may have developed metabolic acidosis or arrhythmia, some hypokalemia or fluid overload. You are giving too much fluid, you don't know. So once they are doing that, you want to monitor them very, very closely, right? And you want to monitor how well they are doing hydration. You are checking again, are they able to drink? How is their skin sugar? Are they making urine now? So on and so forth. And then you also want to assess whether they're now able to drink. Very, very crucial. Because you are treating, they are still not able to drink. It's not a good sign at all. You want to make sure that that is happening. And if you have given your first 6 hours or first 3 hours of 100 mils per kg, and they are still severely dehydrated, you repeat it again. While you're monitoring input and output, urine volume, and so on and so forth, the blood pressure, pulse rate, monitoring is very, very important. It's the second most important thing after fluid replacement. If you don't monitor, you lose them. Okay, so that especially when they have, cholera gravis, you don't monitor, you're going to lose them. Okay, you monitor evolution, you monitor how much fluid they're taking in and out. In most people, they may be placed on a cholera cot where it's a bed that has a hole under. I'm sure we're saying that.
About this issue of housing, I was asking
so that you're able to monitor how much fluid the person is passing through, and you can replace it accurately. But most importantly, also you monitor the level of consciousness, the urine output, and the ability to be able to get out of bed and carry out, the other activities. Then we have complementary therapies, which are those ones that help support the participants, the patient rather, as they do that. Antibiotics, you can see antibiotics comes in after you've done the important things, after you're using fluids, after you're monitoring, you give antibiotics. In truth, antibiotics are recommended for people who have either some or severe dehydration. It's not for all patients that have cholera, that. And it is shown that they truly have no mortality benefit. What antibiotics do is that it shortens the duration of diarrhea, reduces the volume, and also reduces the period that patients are infectious for. Okay, so usually there are quite a number of antibiotics usually are given as start doses, especially in an outbreak situation. A start dose of maybe doxycycline, which is quite widely used oral. But when they cannot take orally, you can use quinolones like ciprofloxacin, which can also be given as a start dose or continuous if there's evidence of ongoing. But it is a complementary therapy, and it is not a cornerstone of treating patients with cholera. In children as well, zinc has been very useful. It's been found to also shorten duration and severity of diarrhea, regardless of their hydration status. So usually they're given 20 to 50 milligrams of zinc on a daily basis, and it helps them recover as well. Feeding is very important, especially in children. You want to make sure they're being fed. Some people may require dialysis or ICU care, and that should be provided. Where that is not available, referral can be made after the initial, concentrations. When should they be discharged? When you have corrected dehydration, when they are now passing less than 3 loose stools, in the over 4 to 6 hours, and where the patient or the caregiver can prove that maintenance therapy can be taken at home adequately without jeopardizing health. Because dehydration can easily occur again if that is not done. So what are the key points? Early detection is paramount, and the cornerstone of treatment is correction of dehydration. If you don't do that, the patient will die. And even if after rehydration, you need to monitor closely. Otherwise, you could lose your milestones, and all the hard work would have been lost. Thank you very much for this opportunity. Over.
Thank you very much, Dr. Akasi, for that very elaborate presentation. At the end of this, I think most of us have revised management modules and be able to manage cases henceforth. So at this point, can you please hold on so that we'll take questions at the end of the third presentation? So at this point, I would like to introduce to us Dr. Abdallah Sanda, who is a consultant clinical microbiologist, has a diploma in IPC from College of Medicine, University of Lagos, and he's IPC lead of Federal Teaching Hospital, Katsina. So please make welcome Dr. Abdallah Sanda, who will take us through IPC measures in cholera management. You're welcome, sir.
Thank you, Ma. Good afternoon, everyone. I hope I'm audible.
Yes, you are.
Okay, so I will quickly go through infection prevention control measures for cholera management. Cholera outbreaks occur time to time in our country and globally, and healthcare workers can help to control it if the right thing is done as far as IPC is concerned, or in certain situations, hospitals and health facilities can serve as places where the outbreaks are potentiated for further spread into the community. Another thing is healthcare worker infections can occur if proper IPC measures are not taken. And we've seen situations where healthcare facilities are shut down because a majority of the workers there have become infected in the course of rendering care to their patients. So cholera is highly transmissible because the stool that is produced by those patients contaminates hands and environment. The bacterium can survive for up to 7 days on surfaces and still remain infectious. IPC strategies are aimed at preventing new infections, curtailing spread, of ongoing infections in our health facilities, in our treatment centers, and in the community at large. So cholera is transmitted through fecal-oral mechanisms, and it is very important for IPC because for us to break the chain of transmission, we need to understand the mechanisms of transmission. The major portal of method of transmission is through contaminated water, especially surface water. During the rainy seasons, they get contaminated and is used as a source of drinking water, can propagate the infection. Other water sources too, like wells, boreholes, and the rest that are not properly protected can serve as points of transmission. In addition, contaminated food, when food gets contaminated during preparation or during handling, can serve as mechanism. Other methods could be through dairy products, egg, cheese, milk. Additionally, transmission can be through fruits and vegetables, especially raw fruits and vegetables that we take without cooking. So prevention is anchored on a number of things. Most important among that is provision of safe water, food, and hygienic practices. Safe water is important to minimize spread of cholera. Water used for drinking and for other purposes is important to be of high quality and available in sufficient quantities. Food hygiene is also important because that may serve as a point of transmission. Additionally, hand hygiene is critical to controlling spread of cholera infection. Then lastly, environmental hygiene is very important when you ensure you minimize open defecation, proper disposal of fecal waste and other waste will minimize transmission of the infection. Yeah. So another modality of prevention is vaccination. There are vaccines available that can be used in prevention and control of cholera. I think we'll see that subsequently. This hierarchy of control for infection prevention and control, from the most effective to the least effective. The most effective IPC strategy when it comes to cholera and other infectious diseases is to eliminate the hazard or to substitute it. Then followed by engineering controls, then administrative controls, and then PPEs. We see that in the next slide. As far as cholera is concerned, environmental control measures and engineering controls are very important in preventing transmission. Availability of isolation facilities in our healthcare units, especially things like cholera treatment units, cholera centers, and then infectious disease isolation units are very important environmental measures in controlling the spread of the infection. Spatial separation between patients. You need to position your inpatients at least 3 feet between. There should be a distance to minimize risk of transmission of infections. Availability of water, sanitation, and hygiene infrastructure is critical. Water supply, hand hygiene, environmental hygiene, very important infrastructure needed for IPC in our health facilities. Safe and effective laundry services in our facilities. This is very important because cholera patients produce a lot of soiled linen, a lot of soiled materials that need to be safely handled, safely cleaned, and disinfected in our laundry facilities. Care of food preparation and utensils, all these fall under engineering and environmental controls. Following this in importance is the administrative controls. These are designed to change how people or healthcare workers work and how they think. And this can be achieved by implementing IPC guidelines and protocols in our workplaces, ensuring regular healthcare worker training, and then importantly, very important, triage at entry points. we need to have triaging points at major entry points in our health facilities to allow for prompt identification of cases and isolation. The last one are the personal protective equipments. Mainly protective medical gown and hand gloves are the minimum, but based on risk assessment, you may need to use other personal protective devices to ensure you eliminate the chances of transmission. Triaging, as I mentioned, is very important for screening patients, identifying likely cases, and then isolating them. Then additionally, notifying the right authorities for surveillance. This should usually be situated at the entrance to the main entry points in the facility. Places like accident and emergency, our emergency pediatric units, labor room, our general outpatient departments. These are places where we need to put triaging facilities at the entrance so that patients can be screened, and those that are identified as suspected could be isolated and then taken care of properly, so that you don't allow them to mix with other patients and increase transmission in your facility. Requirements for a triage unit for infectious diseases include personal protective equipment, triage registers, flowcharts, screening questionnaires, hand hygiene facilities, color-coded bins, etc. The picture is showing our triage station in Federal Teaching Hospital, Katsina, at the accident and emergency unit. Additionally, food handling is very important. Food handlers need to be trained on safe food preparation and hand hygiene at critical times. Surfaces in food preparation areas need to be disinfected regularly with 0.2% chlorine solution. Eating and cooking utensils also need to be cleaned and disinfected with 0.2 chlorine solution and dried in sunlight if possible. Separate utensils should be used for raw and prepared food. Cooked food should be served hot, and if a food item is cold, it should be reheated before serving. Standard precautions are important in IPC because they serve as the first line of defense against infections in the health facility. Hand hygiene is a key component of standard precautions, and it's a single most important measure for prevention of transmission of infections like cholera, which are mostly transmitted through contact and then fecal-oral transmission in individuals. Personal protective equipment, hand gloves, as I mentioned, and medical gown are the minimum and should be used for patients suspected or confirmed to have cholera. Additionally, waste management is critical. You need to manage all waste items, waste materials that are generated in the process of caring for patients that come with suspected or confirmed cholera. Environmental cleaning, critical also because of the high risk of contamination of surfaces and equipment in the care area when patients with cholera are admitted and managed in our facility. Transmission-based precautions are necessary in situations where standard precautions are inadequate, and you need additional precautions to break the chain of transmission and stop disease transmission in the facility. We implement transmission-based precautions when we suspect or confirm cases of an infection that is highly transmissible, like cholera. And it's based on the mechanism of transmission of that particular organism. For cholera, mainly it's contact precautions that are applied to stop transmission in our health facilities. These are the elements of contact precaution that are used for cholera. Patient placement, suspected cases of cholera should be placed in single rooms, preferably. We'll see that in more detail, or should be cohorted. Use of PPEs is very important. Gown and gloves at the minimum. Equipment should be disposable or dedicated for the particular patient. We also need to limit patient transport and movement access restriction, environmental cleaning and disinfection of rooms, management of spills. When we're caring for patients with cholera, definitely there will be spills, vomiting, diarrheal stools, spills can occur in our care area and they need to be managed appropriately. Signages need to be in place when you are caring for patients with cholera. This is a diagrammatic presentation of a single room care facility for a cholera patient. We can see before the entrance, that's what we call the anteroom. For patients with cholera, PPEs should be worn before you enter the room. So the anteroom can serve as a donning area where you put on your necessary PPE and perform hand hygiene. And then when a healthcare worker enters, he's supposed to, after finishing the clinical activity, you can see the direction of movement from the patient. You need to come. Then the healthcare worker should come to the disposal bin for PPE to doff. Removal of PPE should be done within the room before the healthcare worker exits from the care area, and then performing hand hygiene. Finally, then exit from the room. More on contact precautions. The emphasis when it comes to hand hygiene is hand washing rather than use of alcohol-based hand rub. So when we have confirmed cases of cholera or suspected cases, ideally liquid soap and water should be provided in the care area so that the healthcare workers and visitors can use to perform hand hygiene. Gloves and gown, open entry, I think I've mentioned most of this, and then remove PPE and discard before exiting the patient's room. This is a signage that should be used for contact precaution and should be placed clearly at the entrance points into areas where you are caring for patients that have environmental cleaning, also very critical to ensure that you eliminate the contamination that you have on surfaces around the hospital, on the floor, on the trolleys, on the drip stand, and other areas around the patient. And this should be done regularly as part of routine cleaning. And then when the patient is discharged or die, terminal cleaning should be implemented to eliminate the organisms that are left on the surfaces. When we have spillage that contains organic matter, feces, or vomiters, these are the steps to ensure that you take care of it. I think we'll see that in a diagrammatic form later. But the key thing here I want to emphasize is that 2% hypochlorite solution is recommended. That's quite a high concentration when you're dealing with spills that contain fecal matter or vomiters. Those elements. The recommended disinfectant is hypochlorite usually in these concentrations. 2% is recommended for disinfection of dead bodies, stool, and vomiters. 0.2% is recommended when you are cleaning and disinfecting cholera wards, toilets, showers, bathroom, kitchen, and morgue. And then also can be used for PPEs, personal protective devices that are reusable and can be used for food utensils, containers, and even vehicles that are being used to transport patients that have been diagnosed with cholera. The lowest concentration, 0.05, is useful for disinfection of hands when there is no liquid soap and water or alcohol-based hand rub available. But as I mentioned, hand washing is emphasized over use of alcohol-based hand rub in the settings of cholera. These are the formulae for dilution of to achieve these concentrations. Laundry, as mentioned, very important because a lot of soil linen will be produced when we care for cholera patients. And the recommended concentration is 0.2%. And for 10 minutes, initial pre-soaking before washing with detergent. You have to use personal protective equipment when we are handling learning materials that have been recovered from patients that have been managed for cholera. All waste generated in treatment centers are potentially infectious and ideally should be put in red color-coded bags and properly disposed. Incineration is the method of choice. Sharps, liquid waste, soft waste, solid organic waste should all be disposed through incineration after they've been removed from the care area. When we have corpses, as mentioned earlier, 2% concentration of hypochlorite is what is recommended. The corpse is washed with this concentration of chlorine. Orifices are plugged with 2%, with cotton wool soaked in 2% chlorine. The body is sealed in a body bag, and then the outside is cleaned with 2% chlorine solution. Wash is very critical, as mentioned by the previous presenters. Water sanitation and hygiene is critical to control of cholera in our facilities and in the communities. Availability of adequate water of high quality, at least 50 to 100 liters per person per day is the volume recommended to be provided in healthcare settings per day. Infrastructure for environmental hygiene and waste management should be available in our health facilities. Sanitary facilities should also be available and functional. Example, toilets in the outpatient settings and in the inpatient settings should be functional and available for use. These are the 4 domains of WASH: water, sanitation, and hygiene that cover infrastructure for hand hygiene, environmental cleaning, food hygiene, fecal waste management, and healthcare waste management. Lastly, there are 3 vaccines that are available currently for use to prevent and control cholera. Dukoral is mainly used for travelers when they are moving from a non-endemic to a highly endemic region. Shankol and Eucovil are the ones that are available for mass vaccination and control efforts in areas during an outbreak. And I think the country is currently making efforts to acquire one of these 2 for use within the country. But they've been used in several different parts of the world. So far, WHO has estimated 143 million doses of the vaccine have already been released and used in different parts of the world. In conclusion, IPC measures are necessary to prevent new infections and break the transmission of organisms in healthcare facilities and in the community. Hand washing is the single most important measure for prevention and control of cholera in health facilities and in community. Wash infrastructure and services complement IPC measures and are needed to achieve control of cholera infections. The oral cholera vaccines are available and can provide protection for travelers and also in outbreak situations and in endemic communities. That brings us to the end. These are my references. Thank you.
Thank you very much, Dr. Sander, for putting the cap on this wonderful session. Hello. Thank you very much, Dr. Sander, for putting the cap on this wonderful session. We would like to thank all our speakers, Dr. Biodun Oguni, Dr. Yohen Akase, and Dr. Abdallah Sander. Well, my internet was interrupted, so I've lost the chat. I don't know whether there are questions in the chat box, but do we have questions that I would like to ask our presenters before we move on? So while I'm waiting for some hands to come up, I would like to start some discussions with our presenters. Dr. Oguni, we really appreciate your presence despite your ongoing summit. It was interesting for you to tell us that we already have a case fatality rate of 2.8% and that our government is trying to end open defecation in 2025. When we look at the list of challenges you mentioned, we have 48 million people practicing open defecation. Is that going to be a reality? That's my first question. Then secondly, how available are the vaccines? I noticed that part of the responses, you mentioned the vaccine pillar, and Dr. Sander has mentioned that, of course, vaccination is important in the outbreak response. So how available are these vaccines? And I think my third question will be, what is the response to people receiving vaccines in the community the vaccine is available? So before I go on, I can see Dr. Lukman Ademola Lawal has his hand up. Dr. Lukman,
okay.
Thank
you for the opportunity to talk. So you've just taken the word out of my mouth. It's about vaccines, because we keep getting information that is not very, very clear. Are there over-the-counter cholera vaccines in the country? Thank you.
All right. Thank you, Dr. Oguni. Let me repeat what I said. I said you took us through the situation report. We have a case fatality of 2.8% currently, and our government wants to end open defecation, which is one of the major risk factors in 2025. You also informed us that 48 million Nigerians are still practicing open defecation, and only 16% of LGAs in Nigeria are open defecation free. So is this going to be a myth or a reality to end open defecation by 2025? That's the first question. Then the second one, I asked how available are the vaccines in the management of the outbreak response? And if they are being used in communities, what is the response? Are people willing to take the vaccines or not? Then Lukman has just added that, are there vaccines available over the counter, or is something that only has to come through the ministry? So I think you can take that set of questions before we move on. Dr. Guni, you have the floor.
Okay, can you hear me? Am I
Yes,
audible?
we can hear you clearly. We can hear you
Okay,
clearly.
all right, I've stepped out. So thank you, Dr. John, and all distinguished leaders on the call. Yes, about open defecation free status, whether it's a myth or reality, 2025 is how many months ahead, and with the current statistics we have, humanly speaking, it looks, it may be challenging to say that it's possible by 2025. However, when the cholera outbreak started again, we saw that the committee that has decided with this responsibility has also received additional funding to ensure that they can improve this. But because we know that this is meant to be all of government, all of society approach, it's not only government that is expected to help address this. And that is why at the subnational level, we are advocating that every state, if we can have all stakeholders come together to say how we can improve access to toilet facilities. Shopping malls can make their toilet facilities accessible to the public. Motor parks can find a way of coming together to, build toilet facilities. Women can come together and build toilet facilities. Private sector can come together and say how we can have facilities in schools. So then there's also the component of sewage digestion technology that is also being advocated for to help drive this intervention. So we believe that if we take it more seriously and we all play our role, at least Jigawa State is the only state in Nigeria that all these 27 LGAs are open defecation free. So what do? There are lessons we can learn from them, some peer learning, which other states should be able to do. And so we are really recommending that we push harder in this regard. That the current move seems a bit slow, but it's been consistent. About vaccine, if I may add, the current vaccines have improved on the previous one that used to even last for just 6 months. But the current ones available can confer immunity for about 3 years. And we know that it means they have to take booster doses, additional shots after every 3 years. And this is the only option we have for now. And it might also interest us to know that we only have about 1 or 2 companies globally producing this vaccine. And that is why there is shortage of the vaccine itself. And the ICG group, the Gavi group, they only prioritize states that, or countries rather, that have high risk or they are more vulnerable population or high burden of the disease. So for us in Nigeria, much as we started the idea of having the vaccines provided, we deployed it before and we have seen the results in some of the states in the northern part of the country, like Bauchi, for instance. And so it's been shown that it's effective, and you have seen how there's been decline in the number of cases reported. You can see what the cover showed us for 2021, for instance. And the trend we're having this year is not likely going to be like what we had in 2021, because then there was also intervention with the OCV. And so this is giving us the possible results that we are looking at. So it's effective. It's just that, like I said, it's 3 years. So we're also trying to see that maybe it's associated with this 3 years curve that we're also seeing with the spike. But I believe that gradually, much as we may not be able to immediately have access to the vaccine because it's also very competitive, there are the key infection prevention and control methods that are affordable, that are not associated with any side effect that anybody will be anticipating. Just basic hygiene that we're talking about, the hand washing with proper soap and water and all that, environmental sanitation, environmental hygiene, waste management, drainages are clear and all that. These are things that have also been proven to be very effective in controlling this response, this outbreak, which we encourage the people to prioritize rather than waiting for the vaccine that may only confer 3 years, every 3 years from what we have. So there's also the need to do more research to see if we can have vaccines that are more, they're able to confer a lifelong, much longer duration of protection on the population. So it's effective. We've seen it in states in Nigeria that have used it, and the cases have declined. But it's just that it's something you have to top up every 3 years, and that's the main challenge. Then the availability, given the interest that we have seen so far, not many companies are producing it, and you know what that means. It's highly expensive. It's also not as available, and yet we need it. But if we can't afford that for now, let's try other options that have also been proven to be very effective and safer also. Thank you very much. Over.
Thank you for that response, Dr. Oguni. Any other questions before I go on? So while I'm waiting for any other questions, I would like to ask from Dr. Yohen Okasi. Thank you very much for your presentation. Now, considering that we have case definitions for IDSR, case definitions from NCDC, and other technical working groups, which preferably will be used in this outbreak response?
Yeah, thank you very much, Dr. Joan and everyone. So it seems the WHO and the NCDC are in agreement. So they define that once you have acute water diarrhea in somebody 2 years and above, you should suspect cholera. So I think that's what the country is using. Once it's 2 years and above for routine reporting, IDSR, of course, they use 5 years and above, but I think the WHO and the NCDC agree that 2 years and above, is that. Somebody in the chat box had asked about the cholera cot. The cholera cot essentially is it's like a trolley or a bed that has a plastic cover, like a Macintosh kind of thing, but stronger, of course, covered, but there's a hole under around where the bum is, so that as the person is defecating, they don't have to stand up and go to the toilet as the person is, because when cholera patients start pouring, like I said, in an hour, they can lose up to 500 mils and they can become so weak. So they remove their clothes and no pampers on, so that whatever they are passing is passing into a bucket under the bed, so that you can carry that bucket and estimate accurately that, within 1 hour, this person is losing 670 mils or 1 point something liter. You can replace that exactly along with maintenance. So that is the rule of course, if they're going to vomit, they also vomit to something. So the aim of cholera cot is to make sure that you're collecting everything, at least as much as possible, of what the patient is losing per time and replacing it, appropriately. Thank you, Honorable.
Thank you, Dr. Akasi, for that clarification. My internet has been fluctuating, so I tend to lose track of the chat box. So we have NSIC Echo program. Yes, you have the floor.
Do I have the floor?
Yes, Ma, you do.
Good afternoon, all. I want to say thank you very much to our erudite lecturers for this beautiful session. I would say this is the first time that we have the highest participants. And it shows that this cholera outbreak is very timely and we are getting the most for it. Well, my question actually goes to Dr. Biodun Ugni. And I like that aspect about boreholes and contamination of the underground water. And I'm thinking, I know you've already said government is putting together stakeholders at all levels to this response. And I'm wondering, isn't it time for the environmental health officers and some regulatory bodies to start looking into this? Number one is a wash issue, water, hand hygiene, and water sanitation and hygiene. But there's so many boreholes all over the place. I think we need to have some regulation to help, especially in overcrowded areas. Well, you have the target for 2025, but I know we can always shift the goalposts. But then it's making sure areas that are highly populated, like Makoko, where people just do whatever because they are all together and there is no control. And the issue about flooding, I've been listening to the news that there's going to be a lot of flooding. Most states are going to be involved. So everybody here should make sure that whatever we learn there, we go back. We don't keep it to ourselves. We educate all our contacts, all the health workers that work with us, and make sure that we are battle ready. We're not waiting for the thing to start. Even if you have only one case, but that's the one that is, surveillance is not very strong. So at least we make sure we strengthen our healthcare delivery system. So I'm just wondering, this borehole and contamination of underground water, we need the engineers, we need all that. Are we really looking into that? Because that's another issue. I know in the rural areas, it may not really matter. But in the rural areas, we talk about the upstream and downstream. But who is enforcing it? Because if you have rules, you don't educate the community, they will just be collecting water downstream and the water upstream will be contaminated. Over and out.
Dr. Oguni, are you still with us?
Yes, I am. Can you hear me?
Yes, we can,
yes,
sir.
Yes.
Yes. Thank you, Professor Showande, Your Excellency. Thank you for that question. It's good to see you again, ma.
Nice to see you too.
Yes, ma. So about the issue of regulation, I said coincidentally, we're actually attending a legislative summit at the moment, and the issues relating to regulations, legal provisions, and imperatives for public health is on the front burner here. Because we know that for who our people are, if there are no laws that really provide some sanctions against certain behavior, people will do what they feel that they want to do without recourse to how it affects how other human beings. I was in Lagos leading the response at the point, and then I was also in Ogun State, and I was told about a law called Public Nuisance Law. That law actually allows for any house that doesn't have a toilet facility will be compelled within 6 months to convert one of the rooms in that house to a toilet. Otherwise, the house will be sealed up. Now, there are laws, but how about enforcement? So we have had these struggles about availability of laws, policies in Nigeria, but when it comes to enforcement, it becomes a challenge. And that is why we're sustaining the advocacy, engaging states. Something trended yesterday about Lagos State concerning return of environmental Saturday. And people are like, wow, this is going to be good because if I myself, I felt that would be good. Though, at least when we were doing our last Saturday of the month, environmental sanitation, I think we had a reduction in the number of all these infectious diseases. But now we trust ourselves. Everybody felt, no, we need our Saturday for our parties. We need to move around and it's not convenient for us. But we can see the implication. But unfortunately, I don't know. The news came back again and said, Lagos said it's not true that they didn't reintroduce it. So as I don't know which is which. Okay, it's up on okay. So but what we are looking at, right, is that really are these laws meant to make life difficult for us? Certainly no. You remember during COVID when we said people should sit at home, the lockdown and all that. People said no, we need to go and make our daily living. We know that we may not have been able to make provisions for what we need to keep people at home as expected. But it is one principle that has been proven over time that can help prevent the spread of the virus as at that time. But in a nutshell, there are regulations. We were told there are laws, but it is about enforcing it. And one of the beautiful points you also mentioned is that the sensitization, education, and awareness. And that's one of the things I was discussing with the chair of the Senate Committee on Health yesterday, that when we sit even in this kind of meeting, we are discussing with health stakeholders, and it's like preaching to the converted or partly converted. That when we look at WHO defining health, and it says health is not just a state of well-being alone, but talking about physical, mental, it's not just absence of disease, rather talking about the state of mental, physical, social. That social part is not within health sector. There are other factors that are related to that social determinant of health. Housing structure is there, water is there, environmental sanitation is there. So how do we engage all the relevant ministries, departments, and agencies of government in these areas to also play their own role, work on their own regulations, to guide, to support what we need to do? And we need to spread this information. And that's why the Interministerial Committee set up by Mr. President cut across. Even Ministry of Women Affairs is there, Ministry of Information is there, Ministry of Education is there, in addition to the traditional ones, Earth, Environment, and Agri. So we need to spread the message, and that's why I thank God for society like NICS, the front burner, pulling in the weight behind this, well appreciated. And if you can continue to push the message, like when I was in Lagos Island, what I saw in Lagos Island is on part of that city, there is no how there won't be cholera. There is no how. So and I thank God for what Lagos State is doing, they have really gone all head out. I can see the contamination, every waste management process is going on now. But we are saying let it not be a once-off thing. And you can see the results is showing in Lagos because the cases are coming down. But let it not be a one-off thing. How do we sustain this? These organisms will go and hibernate again. All the ones that have been produced from the watery diarrhea now, they are in the environment, waiting for another cycle to begin. So how do we ensure that we sustain this intervention so that next year we don't have similar trend? So we believe that with consistent effort, with more advocacy, with more involvement of everyone in the society, and that's what I talk about, all of society approach, government will play their part, everybody else will play their part. We believe we'll be out of the hood in a function of time. And thank you so much for the opportunity.
Thank you. Thank you very much, Dr. Oguni. One interesting question. Why don't we have cases so far in Enugu and Plateau? Is it surveillance or they really don't have cases?
Surveillance.
I was hoping that will not come up because it's a question that you cannot give a direct answer to. No, but what we call in surveillance or in epidemiology, we talk about true zero. Is it a true zero or a false zero? So a true zero is saying, have we searched everywhere possible and you did not find? Then you write your zero. Or you just put zero because you feel I can't kill myself. So, and you just have to send in your reports. But what we are saying in essence is, well, we have structures in the state. We believe that they are working, but we have also identified their limitation with respect to resources to conduct active case studies. Even the ones that are reporting, there are traditionally hotspot states that are meant to be giving us big numbers that are just reporting like 1, 2, 3 cases for now, which we feel it could also be underreported. due to all these concerns. And that's why we have deployed teams to state, and we're also intensifying efforts with them to see how we can do more active case search before we can comfortably say, but at least for now, as of today, they said no case. And for Enugu sent in a sample to Abuja, which was returned negative. So it shows that at least they are searching. Maybe they have not really found. But when you see a state that is surrounded by states that have all cases, and you see that people are meant to move around every time, and they still tell you it is no case, well, you accept because you can't put a figure that they didn't report. But we know that it is not to now make them to go and relax. They continue to work hard to ensure that they can keep that status. And when they have the cases reported, we believe there's also political issues around that time, but I believe that may not be the situation now. We are encouraging everybody to report, because when you report early, you can provide the necessary response and
so thank you very much to our speakers. We would like to recognize you from NSIC for this wonderful session. So our speakers, Dr. Abiodun Guni, Dr. Yohen Akase, and Dr. Abdallah Sanda. We have some certificates of recognition to present. Amaka, can you please flash our certificates for our erudite speakers? And while she's doing that, please request, we also want to appreciate our audience for taking time out to be with us to the closing points of this meeting. We can see that every part was well loaded with information that we have that we can take to our various communities, various associations, various institutions, and help impact on improving and controlling these recurrent cholera outbreaks that we have. So we'd like to also invite as many of us to join the society, the Nigerian Society for Infection Control. And there are many benefits that you can get: networking, educational opportunities. You have access to all presentations once they're registered with the association. So we would also like to give huge thanks to our host, IECHO India. During the presentations, I could see Alina was keeping the chats busy and going. I didn't see the certificates, Amaka, what's happening? We thank you, Alina, for sharing the slides for us, and also for answering a lot of comments on the chat box, because I noticed the chats coming in and going out. Maybe I lose them when my network fluctuates. Okay.
Done this one before. Start from
So
the
this
beginning.
is for Dr. Akase.
The next one, next one. Amaka, I think it's
Sorry, slide network is not projecting.
Okay, we will send to your mails, but we really appreciate you.
Email. Well, the three of them.
We really appreciate you
have.
for the time you have taken.
Okay.
So please.
Just on a lighter note, to ask Prof if my membership of NICS is still valid since 20.
Please renew membership. Renew your membership.
Please, we are begging, renew your membership. And once you are a member of Nigerian Society for Infection Control, you're also a member of the African Network. Infection Control African Network. So it's dual membership. So please do. We miss you. We want more.
All right. All right.
Thank you. Thank you very much.
Thank you.
So please, we want to thank our audience for remaining up to this point. Can you please fill the feedback forms?
Yes, please.
There are a lot of comments about slides and all. So once you register, you have access not just to these presentations, but even to previous ones and presentations that will be coming up. So next week, we have the Global Hepatitis Day. And for this year, the theme is hepatitis cannot wait. Hepatitis can't wait. Early detection, diagnosis, treatment, and management. So this session we hold before the day, since the day falls on a Sunday, we hold next week Thursday, that's the 25th of July. That's next week Thursday by 2 p.m. So also have very interesting speakers. I know that hepatitis is an issue. It's endemic in Nigeria. So please, let us all be here next week, Thursday, same time, same venue.
Thank you
so much for being a
we should all
wonderful
clap for
audience.
Dr. Ejembi for putting this together. This is fantastic.
Thank you, ma'am. Humbled. And I really appreciate the audience.
Thank you.
Please send the link.
Thank you all.
Membership link.
Please, can you post
collect your email addresses?
Please, can you post it? Amaka, please, can you post?
Okay.
Please do the feedback. Put the feedback.
Do the feedback. If you do the feedback, then the link can be sent to you too. So in case you have not captured your email, once you do the feedback, the link can be sent through the feedback link to you.
Kindly fill the feedback.
So please fill the feedback.
Please, where is the feedback link?
Where is the feedback?
Amaka, please, can you post it? Amaka, please, can you post it?
Alina will share it.
Okay.
Yau ba ni ne wadda out inbound ba gaskiya. Abdad yayi. No, gaskiya she's stable. Da shekaran jiya. Oh, jama'a. No, the thing is that gaskiya ka san why I was very happy when by Tuesday baby now was talking. Shi yasa na ce maza a je a sauko min da maman. Aka sa ta ta yi na ce har ma na ce bari mu fara da 5 minutes zuwa so that it stimulate her da abin nan. To sai kuma ɗazun na shiga gaskiya man cewa na gama na ɗan leƙa inbound because there was one baby da na so in gani that was very sick on Tuesday din and was better amma suna ta neman jini kuma baki ta treating first. Da wata baby da maman ta rasu. Amma bari in kira Aisha Suleiman su ne a inbound din. Okay, haka kace. Ya kuka kare?
We can't hear you, ma. We can't hear you. Unmute yourself. We can't hear you.
Sorry.
Okay, there's a link.
The link is a link there because I can't see the link.
There's a link. There's a link to receive the recorded sessions. But please fill the membership registration by using this link. They can get the recorded sessions for this cholera session we just did.
Feedback.
I've not seen it yet in the chat.
I haven't seen it. Amaka, send a note to.
Okay, the feedback link has now been posted. So please let us have your feedbacks. It has now been posted in the chat box. So I'm going to hold on so that people can have access to the links. So please check the chat box. Membership is just 10,000 naira. So please pay before it increases. We have not reviewed it with the current economic situation. So pay before it increases. And it also gives you access to being an ICANN member. Infection Control African Network. So once you register with NSIC, automatically you become an ICANN member. So it's 10,000 naira annually. We have not reviewed it, so pay before the price changes.
What's the benefit of being a member?
One, you get sessions like this. You have access to all the presentations. You have opportunities for meetings, international and local. You also have opportunities for sponsorship. You also have opportunities for applying to grants, being members of this society. Then, of course, once you become a member, you're also an influencer, not just in your facility or institution, but also in your community. And that is where the whole world, that is where Nigeria wants to be right now. If you remember today's presentations, we have targets for 2025. So you can also be influencers, not just in your institution, but also in your communities. So the benefits are far-reaching. And thank you for asking the question. So all the links are present, the feedback link, the registration link, which also give you access to the slides. Okay, information on how to register has also been posted. The forms to fill, then the account member, but okay, this doesn't have the link. This doesn't have the link. Amaka, there was one you sent earlier that had a link.
Yes, I had shared the link initially, but once they fill the registration form, they're also going to get this detailed information. So I had shared the link on how they can register initially, but I'll repost it again.
All right, thank you very much. So we are still keeping the portal open so people can register.